So again, everyone, thank you for joining me today. My name is Tiffany Robb, and I'm the program manager for the Alzheimer's disease and related dementias program. Our program is a state program and was put in place in 2021 by a lot of you who advocated to your senators and representatives and said, look, Idaho hasn't really invested any money in Alzheimer's and dementia, and it's about time we do so. And so because of that advocacy, my program was established in the Division of Public Health, which is confusing to people. Think, well, we should be at the Commission of Aging. Now, the reason why I had been placed in the Division of Public Health is because there is no cure, as we know, for Alzheimer's and dementia at this time. And so what we know from research is the fact that we are seeing that individuals who adopt a healthier lifestyle and take on healthy behaviors, such as limited drinking, no smoking, managing diabetes, and so on, that actually can potentially reduce the risk of dementia or delay those symptoms. And so in turn, my program is in public health, meaning that we actually are looking at from birth to death, how we can educate Idahoans on how to take care of their brains and try to minimize the risk of or delay symptoms of dementia. And so with that, I'm going to go ahead and get into our presentation today. As I said, the goal of this presentation is navigating dementia. It's a guide for family caregivers. So I get to introduce you to this new guide that we've been working on for quite a long time. And so with that, I'm going to go ahead and switch to the slide. So today in the presentation, I just want to let you know that what you can expect in this today. So I will be going through an overview of dementia caregiving. Understanding dementia is super important. A lot of people, no matter where they are in disease process or how much experience they have, still are confused of dementia versus Alzheimer's. And so I'll help with a little bit of that. And then also we're going to touch upon that caregiver role, of which you've all been talking about or learning about today during this session, but all of you experience on a day-to-day basis because you are. I'm also going to touch upon the different stages of dementia, as well as some helpful resources and then conclusion. So with that, I'll go ahead and get started. Before getting started, this is the cover of the workbook that will be released. My goal is that this workbook will be released by the end of this month, if not at the very beginning of April. This book will be released via print as well as online, and it will be available in English as well as in Spanish. I will provide the link for you so that you can order it for when it does come out, free of charge, of course, because that is what we're using some state dollars for, is to make sure that we can get these workbooks into the hands of family caregivers so that they can have some direction or guidance. I do want to let you know that the funding for this book is part state funding, as I mentioned, but also part of CDC funding. So we receive Centers for Disease Control funding, disease control and prevention funding, I'm sorry. And with that, we're taking some of those dollars and putting it towards getting these printed and out into family caregivers' hands. So an overview of the family caregiver in Idaho, specifically here. In Idaho, we know that we have over 300,000 individuals who step up to caregive an individual in Idaho on a daily basis. Whether that's giving just 1 hour of care up to 24 hours of care. We have individuals of all ages, of all stages, of all races, religions, ethnicities, who are providing care to someone in our state. And those individuals are providing unpaid care, which many of you are familiar with as well. As we look at someone with Alzheimer's disease specifically, we know in our state we have over 65,000 individuals who are providing care for them. It gets a little hairy or sticky when we try to say how many family caregivers we have for people with dementia, because we're not very good at collecting that type of data yet. That's something, as I mentioned, my program was established in 2021, and it is something that I'm really trying to push for is better data collection around dementias. And I'm going to show you a slide of the reasons why it might be a little more complicated than Alzheimer's per se. I also want to let you know that with family caregivers, like many of you, family caregivers in Idaho are working a full or a part-time job on top of providing care. Now, in Idaho, that's 70% of those family caregivers are working, which is actually higher than national average, which is super important as we think about the impact to our economy, to our investments into retirement funds, college funds, and so on. How well are our Idahoans set up for future success as they age, as well as the success of just surviving while they're providing care at this time. And then with our family caregivers, on average, they are spending at least 20 hours a week of providing care, and that is on top of working that full or a part-time job, which is super important as we go across the state and we educate employers about the types of flexibilities or understandings around family caregiving so that we can see how we can create a successful work environment that also supports family caregivers so that they can continue to work. Because what we do know is many of the family caregivers who are working would like to continue working while providing care. And unfortunately, the only reason they end up quitting is because they tend to be forced out of it, not necessarily by the employer always, but because of life, the needs, and so on. And so we want to find ways we can better support the family caregiver and the employer being successful together. Now, here is a glimpse inside the workbook, and throughout this presentation, I'll be giving you glimpses of what to expect within the workbook. Now, something that we thought was super important was the fact that we wanted to make sure that we took pause and focused on you as a caregiver. Now, I should have mentioned at the very beginning of this that this workbook is actually a replication of Washington State's roadmap for family caregivers of dementia. What we had done is we had asked Washington, hey, you have this great tool. Can we take it and Idahoize it and make it our own? And they said, well, of course, let's do that. And we love things like that because that means we don't have to waste resources on recreating the wheel. We can just modify it so it's Idaho. And so with that, what we had done is we had developed the workbook or the guide originally, Idahoizing it from Washington's, and sent it out to family caregivers and asked them about their experience with the book. And these family caregivers were English speaking as well as Spanish speaking caregivers so that we could understand culturally how this workbook was serving or was not serving our Idahoans. And one of the pieces of feedback was, you know, really, I don't know how to talk to people about me being a caregiver. And so that really was the impetus of us creating this section within the workbook, which is different than Washington's, where it is a focus of taking care of yourself. And what we're asking or talking about in this section is really when you're taking care of people or a person, we need to really try and figure out who is your support system. Your support system could be a dog, it could be your horse, it could be your person, it could be your doctor or pastor, it could be a whole bunch of different individuals in there. And so what we wanted to do was encourage you to think about those individuals and draw out your care map. Who are those individuals or entities or things that you would go to give yourself a reprieve, a break, or a moment of sanity when it's needed. And so then on the side, what we wanted to do was kind of guide you as a caregiver on identifying, giving those entities or individuals' names and then putting, marking how they can best help you. And what we have heard over and over again, especially when an individual is caring for someone with Alzheimer's or dementias, is the fact that, well, Tiffany, I had lots of friends, or so my spouse had lots of friends, but as soon as we got the diagnosis, they started going away. And what I've heard from friends of individuals is, I just didn't know what to do. I felt like they were so busy and working so hard, we didn't know what to do. So we're really hoping that maybe this could be the first step at helping individuals and family caregivers, is by having them identify their care team or the people, and then saying, I need help with some research of resources, or I need you to just be my emergency contact, or whatever the case is, giving you those words to start. Now, as I promised, and had said early on, it's really important for us to understand the difference between Alzheimer's disease and dementia. And the thing is when I was growing up, we would hear of things like, oh, well, that person's senile, or the person, they're old, and, then they have old timers. And that, what we know in our society, and this, I hope it doesn't sound, what we know is that we idolize and just so desire youth. We have not embraced age in our society. We have not taken individuals who are older and put them on the pedestal, or thought of them as wise and sage, as other cultures may have. And, frankly, sometimes one of my grandfathers, it'd be really hard for me to think of putting them on a pedestal, because he was quite a feisty bugger in his life, and maybe not a likable creature most of the time as well. But the thing is in our society, we're really wanting to try and change the idea and understanding of what is real age and what age offers us, which doesn't always have to be scary. But also, then, when something's happening to the brain that isn't just because of age, but is because of some deterioration. And that's where we get into Alzheimer's disease and then dementias. And Alzheimer's disease is a specific disease that's going in there and building up plaque, similar to if I have a heart that, well, I do have a heart, but similar to my heart, if I'm eating a lot of fatty foods and I'm not getting exercise, I may get plaque buildup in my arteries and my vessels, which causes restriction of the blood to get to my body parts, as well as to my brain. So Alzheimer's causes those plaques and those tangles, which then strangle the synapses so your brain can no longer communicate, thus causing the brain to start to die off and deteriorate and shrink in areas. So when the brain starts to die off and shrink and deteriorate in areas, then that causes our brain to no longer maybe allow us to communicate verbally the way that we are used to. And so in turn, we may lose our ability to vocalize things, or we may lose our ability to remember things, or to walk, or to do those daily activities like toileting ourselves or bathing. And when Alzheimer's gets to that point of creating that deterioration in our brain, that's what we call Alzheimer's dementia. And dementia is this umbrella term that's when things have impact our cognitive ability to the point to where we're no longer able to do the things we once were able to do, because our brain has deteriorated, or there's been some sort of trauma that's caused it to where it's no longer functioning in the same. Now, again, at the bottom of the screen, you will see Alzheimer's disease will become Alzheimer's dementia in most cases, but not all dementias are Alzheimer's disease. And that's why I want to come to this next page, which is a page out of the caregiver guide that talks about dementia, so that you can feel better informed. And I think the thing is Alzheimer's disease has really gotten a lot of the spotlight for a lot of years. And I think it's because that's what we knew and know. But as we continue to learn, we learn that there's things that are causing damage to our brains over time, or there's a genetic component that we were born with that we will over time get damage to the brain, or our brain will start to recess or regress, sorry, and thus that causes dementia. And as we continue to learn, we're going to find that there's going to be a lot more dementias out there. And as you can see, even from this umbrella here, there are quite a few dementias here that are not related in any way to Alzheimer's disease. Now, the thing is that individuals can get diagnosed with Alzheimer's disease, but then down the road they'll find out, oh, really, they had this. It's really hard for us to diagnose, or for physicians or healthcare providers to diagnose Alzheimer's or any types of dementias until we get those cognitive impairments. And then it's still a figuring out of why I stopped talking, or why am I stumbling all the time? Why am I, doing whatever it is, having outbursts, emotional outbursts all the time, when that was not my norm before. And so there's a lot of blood tests, there's a lot of scans and things that healthcare providers will do to try and figure out what is causing that dementia state. And so again, as we continue to learn, we will find out there's going to be a lot more dementias out there. And like I said, as I started on this slide, Alzheimer's is kind of taken center stage, but I'm curious to see how that will continue to go as we continue to progress in our knowledge of that. So I want to touch upon the caregiver roles, and this is probably not anything new to any of you. If you are a family caregiver, or if you have any loved ones, I'm sure you've probably done any one of these tasks. It's important for us to understand what a family caregiver is, and the reason why it's important for them to identify as a caregiver. If we can get individuals to identify as a caregiver beyond what, like Dara was talking about earlier, of how she was a mother, a daughter, a granddaughter, and so on, this helps her then associate and find other individuals who are similar to her. And why is this important? Because many family caregivers, especially family caregivers who are caring for someone with Alzheimer's or other forms of dementia, will end up isolating. And we know that isolation is not a healthy thing for our families, for our family caregivers, and for a person with any kind of disease interfering. I'm so sorry. I'm at home and I have dogs. I apologize. So with our family caregivers, they can be simple tasks that they could be doing. For instance, I would go to my grandpa's house in the summertime, and I just knew that when I showed up at grandpa's house after grandma had passed away, I would clean his refrigerator out. And then my aunt and I would start looking over his checkbook to make sure that things were, being spent appropriately and there was no crazy spending that was going on, and so on. But over time, those chores and those responsibilities tend to grow. And that's definitely the case that happens with family caregivers who are caring for someone with dementia, is that those tasks and those responsibilities will definitely grow. But what we want to make sure of, that family members and family caregivers understand, is that there is going to be a time for you to jump in and take control, because you'll need to and have to. But try not to jump in and take control before you need to and you have to. Preserve that energy in yourself, but also preserve that identity and independence of the care recipient. Because allowing the individual to be as independent as possible for as long as possible and as long as safely possible is super important for both your sanity, their sanity, and both of your preservation in this. And so with our family caregivers, Let me go ahead. I'm going to switch to the next slide here. Inside the workbook with the family caregiver, what we do is here. I just wanted to make sure within the family caregiver section, of course, we have the individual identifying and looking at themselves, identifying their care team. But then what we've done is we've broken it up into different sections of kind of a guide for this journey. So in this section of, with the family caregiver, we want to make sure that the family caregiver has some basic resources, whether that's the Alzheimer's Association, their local area agencies on aging, or their community care program, which is a newer program across the state that not many people are aware of. And those are individuals who provide dementia support to family caregivers through the area agency on aging out of Meridian, but again, they're statewide. Now, in the little blue box is kind of a call-out box, and this box here is just telling you that we're going to be going through different stages of dementia throughout this workbook. But these stages don't flow in beautiful order in real life. And the thing is don't think that you have to do everything at once. What we wanted to do is just break out some action steps for you that might be helpful in this specific stage. Of which here you'll see on the right side of the screen is for the first section is that mild cognitive impairment. And mild cognitive impairment where, you know what, it could be me at my age, I'm 48 years old, and I could be experiencing mild cognitive impairment. Maybe I'm starting to notice that I'm forgetting things. Maybe I'm stumbling upon my words a little bit. Maybe my moods are changing quite a bit. There could be some things that are happening that I'm dismissing at this point, but they're kind of little red flags in the back of my mind. And during mild cognitive impairment, what we know from the research so far is that some mild cognitive impairments do transition into stages of dementia, but some cognitive impairments do not. And I'll share personally with you that when I was 39 years old, I was experiencing cognitive impairment. I was having major memory issues. I couldn't remember a thing, and I was having severe mood swings. I had gone into the doctor, and they had given me blood tests and found out that my thyroid was not working. So my mild cognitive impairment was reversible because of the fact that I was put on thyroid medications for the first time in my life, and I was able to finally get my thyroid to start working again for me. So things like our thyroid, vitamin deficiency, vitamin B and D deficiencies can be big ones, and other things that could potentially be causing mild cognitive impairment may be reversible. And so it's very important if you have concerns and are experiencing these things that you go and get it checked right away in case it is something that can be reversible. So here, as you'll see on the right side with this mild cognitive impairment, there's specific action steps that we've outlined. And we've created a little area where you can write things in as well. We wanted this to be a workbook, something that gets you active and involved, which is why it will be available in print as well as available online for you. Now, here's the unfortunate part is the online portion. If you were to click on these lines, there won't be the text option there. So I'm so sorry. We're just not that clever in our design. And I didn't want to spend a lot of money on that expense of developing something like that where I can use our state dollars and other resources. So as I promised, I would go through the stages of dementia, and as I had mentioned just a moment ago, the stages of dementia do not necessarily go always in a perfect order. And so although we have these lined up here, there's experiences that may happen in early stage for some individuals that may not happen until mid-stage for other individuals. And the same with early stage and mild cognitive impairment. Nothing's linear on this, definitely. The thing is I may be wondering and worried And when my person, if I take them in to go and get diagnosed, they may already be in a mid stage or a late stage, and we just were ignoring and not paying attention or were ill informed. The other thing is some individuals may be wondering and worried, and they may be catching things at the early mild cognitive impairment stage. So again, nothing's linear. And so I'm just going to touch upon a few of these and show you at the same time what the workbook looks like inside. So on the wondering and worried section, what we have is a little bit of, is everything okay? Is my person, are things okay? Or maybe it's myself. Am I okay? Is this forgetfulness? Is something going on? Should I be getting checked? And generally the thing is if there's a concern, we probably want to go and get checked. Well, we try and let people know and encourage them on is we don't mess with our brain. So if our brain is telling us that something's not right, let's go and get it checked so that we can figure out what it is. And then what if my care recipient doesn't go to or want to go to a healthcare professional? We can actually start helping with getting resources for you on that, because sometimes you might have a spouse or a partner or a parent who isn't willing to go and get checked because maybe this is scary, or maybe they've been concerned about this for a while. And society has really created an ugly image of aging and of dementia. And so nobody really wants to jump into that one to experience it really, for sure. The other thing that we've broken up or the book into is what should you expect at this age? And the reason why this is important is because many of our family caregivers are family caregivers as well as a spouse, as well as a daughter, as well as someone else. And you may or may not have heard a term used earlier called identity discrepancy. Identity discrepancy is where me as a wife to my husband, I married my husband, and when I married him, he was a certain way. And then all of a sudden, he's 15 years, we're 15, 20, 30 years into the marriage, and all of a sudden, I'm having to provide a lot more care to him, and he's no longer the same person I married and had that relationship and image. And that's an identity discrepancy because I miss my husband. I miss that relationship of being wife and husband. But now I also have to be caregiver. And the problem with that is the fact that when I'm wife, I kind of get cranky at my husband because he's probably doing that because he's just being a jerk. Versus, oh, wait a minute, if I could be in that caregiver mode, he might be doing this because of his brain or something else. And so that's the identity discrepancy. It's kind of like the angel devil on your shoulder fighting, trying to figure out why this person is acting the way that they are. And so the reason why I bring that up is because the what should you expect at this stage will maybe help remind you that these things are actually normal things that are going on. And if it's normal, it's probably not because your spouse or your parent is being a jerk. It's because the brain is causing them to actually do this. And so this is why. Okay, so mild cognitive impairment. Again, mild cognitive impairment is when it's not yet dementia. It could potentially be reversed and or it may go into dementia. But mild cognitive impairment, again, we have those what you may be wondering, and then the what you should expect from this stage. And this you'll see like down at the bottom, you may find yourself grieving or feeling angry or depressed or wanting to really control those situations. And that's what I was saying earlier, as a family caregiver, what we really want to try and encourage is feel that grief, be angry, be sad, find happiness, but try not to control until you really have to step into that controlling space. And the reason is because you are taking away a person's individuality and their independence while they still can do things. And your exhausting yourself prematurely. And so we really want to try and help support you in that process, which can be hard, especially for an individual like myself who likes to take control. The early stage of dementia, here again, we have those sections of where you may be wondering, is our paperwork in order? Should my person still be driving? How can we stay active? I had an individual who called me last week and had said, I really wish that my person's people would come around and visit. The phone calls are getting shorter because my person, sees something and gets distracted and the conversation goes that way. And so we looked up some resources of how to educate and empower those friends and those family members who would usually call and give them the information that they need to understand this disease. But also the other part that I thought was super important for this individual was to express to those family and friends, when you call or when you take my person out, that provides me a break, and that provides my person a break from me. And that is more valuable than you know, which is so, so important. And so trying to really try to figure out how we can remain active as family caregivers and how the individual can remain active as well is going to be so important for both of you. And again, what you should be expecting. Again, the trajectory is not linear, but these tend to be very similar for individuals in those early stages. My processes might get more complicated to me and I can't figure it out. I need reminders, a lot of reminders. And here is at the bottom, you see the moods or the personality changes, which definitely happen quite a bit with many types of dementia. We have mild stage dementia, and here, again, this is where the person should still be able to remain very independent for the most part, but this is where we need to start making sure that the home is safe. This is where we look for fall risks. Why? Because an individual who has dementia, if they go into the hospital because they've tripped and fallen, and the healthcare provider does not know that the person has dementia, they may be put on medications that are not safe for them. They also may have a very traumatic experience in the hospital. What we want is we want individuals who have dementia to go into the hospital and to their doctor's appointments for necessary things, but we want them out of there as soon as possible because hospitals are scary. And hospitals are not a very welcoming place for individuals with dementia. No matter how dementia friendly a hospital is, it is not home for an individual with dementia. And so we want to make sure that their home environment is super safe to reduce the incidences of them going into the hospital, whether that's falls, whether that's medication management. Again, should we be looking at driving now? Is that something that, do you need the doctor to step in and say something? Or do you need to work with the DMV? Or, maybe you need to sign a contract with your person and just have it on the refrigerator that says, we both agreed that at this time you would no longer drive. Or maybe it's a matter of, we just pull the plug on the battery and the car no longer works. Darn it, kind of a situation. So again, there's the wondering, and of course, then what you expect. So those medications are super important. We know that our population, as we age, our 65 and older population, we take more medications. And when a person has dementia, there's more probability of them messing up on their medications, whether that's missing medications, overdosing on medications, or just scattering them all over and taking them all at once, kind of a situation. Those kinds of incidences of medication mismanagement end up putting individuals in the hospital at higher rates, of which we want to really discourage, if at all possible, which is why we want to get on top of medication management as early as possible. Of course, following instructions, what I've heard from family caregivers is, Tiffany, I put stickers all over. I have Post-its on the cupboard that say this is where plates go. I have posters, stickers on this and stickers on that, or this is, I've written the calendar out and my person knows that they need to follow steps A, B, and C that are written out. Again, empowering the individual who has dementia to still remain as independent as possible. It creates some innovation, or it makes room for innovation. And sometimes we're exhausted and we don't have time for innovation. So it's easier for us to just take control and do. But again, trying to remind ourselves we don't want to step in until we really have to, because this empowers them, reduces conflict actually, and can preserve our energy. Okay, and then I promise I'm actually almost done here. So then we have the late stage of dementia, and this is our last stage of dementia before death, of course. So late stage dementia is where we're really focusing with the individual. How do we just make sure that mom is comfortable? We just want to really make sure that, people can come and give her love and be there by her side, because we know that maybe she's not communicating now, or maybe she's not able to get around, maybe she's not eating, but how can we know and get the people around her that she loved to surround herself with all the time before dementia? So really promoting that quality of life. We really want to figure out what care is the best care for the care recipient. So what care does my mom want? And how is she going to receive that? How can I ensure that she receives that best care? And then what are those medical care or end of life care decisions that my mom had determined? Hopefully we've had those conversations when she was cognitively capable of making those decisions. And how do I best honor that? And this is something that we recommend is, if you have a spouse who would do anything to make sure that they saved you, I don't know if that spouse is probably the best person to make your end of life decisions for you, because it might be very, very hard for them to say it's time to let go. And maybe they will be able to, but sometimes that's where we find an attorney or a doctor or a friend or a priest or somebody who can make that decision for us. I don't know if priests can do that, so please forgive me if that was not appropriate. I apologize. The other thing on there is, of course, as with all of the workbook in the different stages, is what you should be expecting at this time. This is really, unfortunately in the late stage is where respite, or not respite, but hospice comes in or is pulled in. And unfortunately, hospice tends to be pulled in the very last few weeks, which my thing is please pull hospice in as soon as possible, as soon as your doctor says, let's pull hospice in. And the reason for that is because hospice allows someone else to come in and provide some care and support and help answer the hard questions. Hospice can get a physician or a nurse to the house versus you having to struggle to get your person to the clinic or to the hospital. Hospice can provide those check-ins and that comfort and that religious comfort to you as well. The thing is with hospice, technically, a person cannot be in hospice if they have more than 6 months to live, I think is what it is. Karen, do you remember? I see your face, so I'm going to call him. I think it's 6 months.
Yeah, I think it is also.
Okay. Yeah, 6 months to live. Now, the thing is in some states, they do have different definitions for that for an individual who has dementia. And this is something that I know we have a couple of healthcare professionals in our state who are really trying to figure out how we can get that embraced a bit more, because dementia just is so complex, and the individuals need so much care, and our caregivers wear out so quickly. And this is a long process for these, generally speaking. So here with the late stage, this is where, again, you'll have what you're wondering most likely, and then of course what you should be requiring or what you should expect in this in here. Okay, and so with that, I'm going to go ahead and go to the last couple of pages within the workbook. In the workbook, we wanted to make sure that resources were available. As I mentioned at the beginning of this presentation, when we were established as a state program, we were evaluated through our legislative body. And what that evaluation was, is it was a evaluation conducted by the Office of Performance Evaluation, which is a nonpartisan group that works with our legislative body and evaluates specific areas. And when they had evaluated our state, they had found that quite a few people who received a diagnosis of dementia or their family caregiver received one just did not know where to go or how to begin this process. So what we wanted to do, and this was a big reason why we wanted to replicate the workbook for our state, was we wanted to get this resource out there to individuals and make them aware of existing resources in their communities. We found from the family caregivers who had looked at this book, they had said, I didn't realize that there were actually so many resources in our state. And we're not a resource flush state. We are a scrappy state who is really innovative, and we rely upon a lot of partnerships and relationships to get things done. And we're noisy. We work together really well. And so it's important for us to make sure that we maximize the resources that are available in our state. And so in this book, there are those resources, whether it's with Karen being on the call, through Janice, which is through the whole Treasure Valley area and helps provide resource or respite support for our family caregivers, or maybe it's providing powerful tools for family caregivers, which is another resource that they provide, as well as many others. The other thing is that we wanted people to really understand that, again, not all resources are alike in our state. So the thing is we have 6 area agencies on aging across our state, but it does not mean that all the area agencies on aging provide all the exact same services and supports at the same amount of dollars available, and so on. So it's very important that you have those supports available, that you also know how different they are. So we really hope that we can help provide information to inform and empower you as well. And so with that, these are some of the resources that we put in the resource guide for you, or in the back of the workbook for you. The dementia quick tip sheet was just pulling the 12 signs and symptoms of dementia for you. We also have communication tips, so that way you aren't, when mom says, Dad, where's Dad at? That Dad died 15 years ago. You don't say, well, remember, Mom, Dad died. Because unfortunately, that takes Mom through a new grieving process every time she's reminded, but also you're questioning her memory. And that makes her feel insecure and unconfident in her abilities in that area as well. And so that's where we actually do encourage some white lies and say, Dad's working, he'll be home later. So, and really honestly, I think it's okay, but I don't know, maybe check with the people upstairs. How you feel. But really, if we can provide those opportunities where it's less conflict between caregiver and the care recipient, and we're not creating such pain and trauma again for the individual who has dementia, I think that's very important for us to provide that dignified care and quality care. Now, remember how I opened up the presentation and I said the workbook at the beginning is about you as a family caregiver, focusing on you and how you build your support team. what we did is we put at the very back, the very last page is a page that you'll be able to tear out that has these tabs that says, who are you? You're part of my support team. And then I would like you to support me by, and then you can give these out to your friends or to your family members or to whomever it is to help facilitate that. We did have family caregivers who said, I really think I want to give them a whole workbook. And I said, why not? Because really, they're a caregiver. If they're supporting you, they are a caregiver as well. And we want caregivers educated as much as possible. So again, trying to facilitate as much as we can, giving you the information. Throughout the book in the very back, there's helpful resources, making sure that you have those resources too, whether it's the hospice agencies or the Janus or the area agencies on aging, or maybe it's the community care program. All sorts of resources and links will be back there. The thing is you will see on this document here that the resource, unfortunately, the URL is spelled out. And that's because of the fact that this is a print copy for the individual, which unfortunately I can't push on a thing and the link and get it to direct me if I'm looking at a paper book in front of me. So you'll need to unfortunately type it in. And so with that, this gives you an idea of those resources that would be in the back that hopefully will be helpful for you as you go through this workbook. And so with that, I just want to say thank you so much for taking the time to go with me through the workbook today. I will stop sharing my screen here so that I can put in the chat the link for where the workbook will be available to order for free or to download, so you can have it in print or in download once it's available. So I'm going to go ahead and stop sharing, open it up to any chats, comments, thoughts, and otherwise, yeah, I'm going to stop talking.
Tiffany, this is Lynn from the Commission on Aging.
Hi, Lynn.
And I should have the answer to this, but you were talking about mild stage wandering. And I know Idaho has the new emergency missing person. Is there a place where people can go and register their person? I should have this answer, and I don't.
Yeah, so I would actually, it's not the same in each county, unfortunately. So you would actually want to, what we recommend, and I think it is in this book, and please forgive me because we've been working on this workbook for a year, as you know, Lynn. I think that in there we encourage you to reach out to your county sheriff or policing agency and ask them if they have a registry. We have what Lynn's talking about, if you all are not familiar, is we had what was called an endangered and missing persons clearinghouse within our state. And what that was is that's a website that you can go to. And I don't know the URL offhand, but it's called the Endangered and Missing Persons Clearinghouse. And within that, what you could do is you could say, my mom has left, and this is what she looks like. And then she would just be in that database so that if police or law enforcement were out, they would go and find and came upon her, they would be able to locate her and place her. The thing is as Lynn had said a couple of years ago, under the guidance of Lisa Anderson from the Alzheimer's Association, she had partnered with American Indian, Native American, because we have so many indigenous women who go missing. Michael Vaughn, you may be familiar of, who was a child who went missing, but because they didn't have specific car identity and know that he was abducted, he didn't qualify for the Amber Alert system. And so Lisa Anderson had worked with a whole group of individuals and said, let's create an emergency or endangered and missing persons alert so that way it can help anyone who goes missing. And you've probably all been recipients of the pain when it goes off, and you hear now of a 70-some-year-old or a 90-some-year-old who's now been missing. That is the work that just had happened recently. But long answer short, Lynn, check with your sheriff and local law enforcement and see if there's a registry. And that could be something you could even encourage that they start creating, is a registry. Sorry.
Thank you.
I'm going to grab that one link for the health tools. And I saw somebody had said that dementia is a qualifying factor for hospice. Is it Elena? Elena? What, can you go into more on that? Are you saying that it qualified you earlier here in our state, or how does that work? Yeah. Okay, that does. Okay, perfect. Thank you so much. Sorry to put you on the spot. So I say push hospice as soon as you can with your physician. And it doesn't necessarily mean when your physician says no, you need to just check and make sure as well, because it does, a healthcare professional, although they have a lot of education and information, don't always know everything right away. And so this is a way that you can learn together. Always advocate for yourself and your person. Of course. Yeah, they send shower aids 2 to 3 times a week. Oh my gosh, yes. Those are golden. Yeah, let me get the whole tools here.
Hi, Tiffany.
Hi, Tina. How are you?
And you?
I'm doing well. It is good to see you.
Yeah, same here. When it comes to hospice, they have to have problems with their activities of daily living for them to actually qualify.
Okay.
Medicare has a real strong point of view on when they can qualify for hospice.
Right. Okay, so it might, so if it's Medicare, you think, Tina?
Yeah.
Okay,
I
so-
mean, Medicare's not easy to work with when it comes to hospice.
Okay. Yeah. Yeah, so maybe that's what it was, is they were talking, the physicians here were talking about, maybe they were trying to go national to advocate for it, or if there's some push right now for that. I honestly, yeah, I haven't had time to focus in that area.
Yeah. Medicare does pay for like respite, which is 4 nights, 5 days. And you can get that through an agency where they can send them to a home or to a facility. And then, but the ADLs, I mean, to stay on hospice, you have to decline
Mhm.
for the longer period. And there are ways to word it where they can stay on longer. I mean, I had my mom and my husband both.
Right.
And so depending on how the doctors and the nurses write it is really going to be the decision maker.
Right.
But they can always call a hospice company and say, look, this is what's going on. They can come out and evaluate them. And then they can go to their PCP and request them to be put on hospice.
Well, and Tina, I think you bring up a good point there, because I remember when I was over at Family Caregiver Navigator, just trying to really push our families to really advocate, get your person reevaluated. If they've
Right.
not evaluated, get them reevaluated, because
Yep.
it doesn't take long for a person to deteriorate. And if you have to wait a whole year, that's ridiculous in some cases. It's too much work.
Yeah. Well, if I remember right, it's every 3 months that they have to be evaluated.
Yeah.
And then every 6 months, they have to re-sign up for hospice. I'm having to go back 3 years now. It's been that long.
Has it been that
Um,
long? My gosh, Tina.
But yeah, I mean, most hospice companies are willing to work. So all they gotta do is find one, call them up, and see what they have to say.
Okay. Well, I appreciate you being here and vocalizing that. That's so important and it's helpful.
Yep.
And it looks like Lena was also saying, that she's not had problems with getting her individuals qualified and the evaluation process as well.
Yep.
Any other comments, thoughts, suggestions, or
I'm happy to say just a little bit more on that too, just from a health provider perspective. So I'm Dr. Weiss. I'm a geriatrician with St. Alphonsus, and for someone to qualify for hospice, they qualify for that benefit when they have a life expectancy of 6 months or less. And so when we look at patients with dementia and particularly with Alzheimer's disease, because we know that Alzheimer's progresses in a pretty predictable, slow manner, when it comes to their functional impairments, patients typically don't qualify for hospice until they have become dependent on most of their basic activities of daily living. So that includes needing help with getting dressed and toileting and bathing. And so oftentimes patients don't qualify until they're in those later stages. But always good to talk to your doctor and healthcare providers. And there certainly are different situations, but that's generally how that looks and works.
thank you so much, Dr. Weiss. It's always good having somebody in the room who can help out. Tina and Dr. Weiss, good job. Well, thank you all so much for joining me today. I did put the link to the workbook in the chat for you. My hope is that it will be released at the beginning of April and we can get it mailed out to you as soon as possible. Our goal is to get it in the hands of healthcare providers, service providers in our community, and so forth. So thank you, and may you have a wonderful weekend.